the title. So this is called Freezing of Gait and Parkinson's Disease. I'm Brent Bluett. I'm a movement disorder specialist, and I currently work at Stanford. And we'll talk today about freezing of gait. And if everybody can mute their ends, because I can hear a lot of kind of chattering. Everybody knows how to. There we go. Thank you, guys. All right. So what is freezing of gait? So it is a brief episodic absence or reduction of forward progression of the feet despite the intention to walk. So people feel like their feet are glued to the floor and they're unable to move. It's a horrible, horrible condition. Typically occurs in 5 conditions: starting to walk, attempting to turn, going through a narrow doorway or passage, nearing one's destination. And I didn't put the 5th, but my research has shown that it also happens a lot during dual tasking when trying to do 2 things at once. It is most commonly seen in Parkinson's disease, but it's also seen in other Parkinsonian syndromes. And that means like multiple system atrophy, progressive supranuclear palsy, and it can be seen in normal pressure hydrocephalus, or people with strokes in certain areas of the brain that can cause freezing of gait. These areas, these strokes have kind of given us some insight into where exactly the part of the brain that's involved is with freezing of gait, and I'll talk about that a little bit later. But I wanted to show you an example of what freezing of gait is, because I can talk about it all day. Excuse the horizontalness, don't get vertigo. Try to watch. You can see here this is one of my patients, and she had a really difficulty moving her feet, especially going through doorways. In a wider situation, a wider hallway, she's able to walk better, but you can still see how the feet get kind of stuck. So people describe this like their feet are either magnets or glued onto the floor. It's extremely frustrating, extremely scary. I'll tell you right now, not everybody in Parkinson's disease gets this. So if you don't have it, I hope you don't get it. We're working on ways to treat it. But you can see here again, she just has difficulty. She gets going a little bit more easily when there's a wider area. But you can see again that right foot kind of stuttering. Yeah. And then turns are also a huge source of difficulty for people with freezing of gait. You can see how hard that is. So imagine this, for those of you who don't have this, imagine walking and all of a sudden you get paralyzed and it just happens suddenly. And you can imagine how terrifying that is, how horrible that is, and what it can cause, and it leads to a lot of falls. So it's my area of research is falls prevention. That's my focus for my career. So obviously freezing of gait is an area of research for me as well. So we call Parkinson's disease freezing of gait PD fog. It occurs in about 50% of Parkinson's disease patients. 60% of these times it happens in the quote-unquote off state. For those of you who don't know, the off state is when the carbidopa, levodopa, or other dopaminergic medication for Parkinson's disease is not actively working. When it is actively working, it's called the on state. We want, as a movement disorder doctor, I want all my patients to be on all the time. 36 to 38% of the episodes occur in the on state as well. So this differentiates these 2 different kinds of freezing of gait. There's levodopa and non-levodopa responsive freezing of gait. The former means that if you're off, you have freezing, but when you're on, you don't have freezing. The latter means it can occur in either the off or the on state. Usually seen in later stages of Parkinson's disease, 70% of the time, but 26% of patients with early PD, not yet exposed to therapy, can develop freezing of gait too. It is one of the most debilitating motor symptoms of Parkinson's disease, and it's a significant cause of falls, disability, and decreased quality of life. So here's a little bit of research that I did, and I'll try to simplify this. All research is complicated. But what we looked for, you can see here in the introduction, or excuse me, the objectives are a little bit more useful, to identify the early symptoms which predict those who will actually get freezing of gait later. And so please just ignore this. This is just the numbers of the people who were involved in the study, people without freezing and people with freezing. They were matched. That's very important when you publish literature on research. What we really found, the important part is that the predictors of later development of freezing of gait are people with excessive daytime sleepiness, REM sleep behavioral disorder, so that's acting out dreams and talking in one's sleep, and also people with higher anxiety levels. We did not find any cognitive components that were related to freezing of gait, although other studies have found that set shifting, which is basically an ability to kind of go from one activity to another as quickly as possible, is delayed in people with freezing of gait. And what we really found from the study was the area of the brain that's involved, which is shown down here on the right, bottom right-hand corner. And this is called the locus coeruleus and pedunculopontine nucleus. Hopefully you guys can see my arrow. It's this little area right here in the brain. This is called the brain stem. It connects the spinal cord to the brain, and this is the area that's affected. So we have different ways of assessing those who have freezing of gait. There's something called the freezing of gait questionnaire, and it simply asks, do you feel that feet get glued to the floor while walking, making a turn, or initiating walking? And this is freezing. And then it asks, does that happen ever, rarely, very rarely, often, or always? We found that this is very overly sensitive, and so people who don't even have Parkinson's will say, yes, my feet get glued to the floor when I'm walking. So this was not a great way of assessing the freezing of gait. There's a newer freezing of gait questionnaire. This includes a video that you can demonstrate to people. So it shows kind of what I showed in the non-horizontal way of people with freezing of gait. We have this MDS-UPDRS-3, that's the examination every Parkinson's disease patient does, where you go in and do this and open your hands and flip over. And one of the items checks for freezing of gait. But as you can imagine, that's a snapshot. That's a 5-second walk and come back, and very unlikely I'm going to be able to catch freezing of gait in that 5 seconds. We found in the study that we did only 20% of the time do we actually see freezing of gait in people coming into the clinic. There's something called a timed up and go. Anybody who's been to physical therapy for Parkinson's has done this. Cross your arms, stand on up, walk, come back. That is a kind of a bit of a crude way to assess for it, but a lot of studies have used that. And it's a measure of assessing fall risk, but not necessarily freezing of gait. And then we found that there's something called a freezing of gait assessment course. It's called a FOG score. And this is a validated physical therapy assessment to evaluate for common triggers of freezing of gait. And it includes all those things we talked about before. You have to stand up, start walking, turn in a circle, turn back the other way, go through a narrow doorway, then do it while carrying a tray, and then do it while carrying a tray and counting backwards. So you can see how that's difficult for anybody, myself included. I might fall. So it tends to induce the freezing of gait, though. And so that's kind of the best way we found to assess for freezing of gait. So that's a little bit research oriented. Everybody here who actually has freezing of gait wants to know what they can do right now to treat it. Okay, so the visual cues to prevent freezing of gait have been found to be very effective. You can see here, these are newer. They actually developed laser lights that project from your shoes. This is available online. What it does is you basically imagine, or now that you don't have to imagine, there's a line in front of your feet, and all you want to do is step that left foot over that line. Tune everything else out and just focus on doing that. And that's found to be possibly the most effective way of treating freezing of gait. Oops. So then they have visual and auditory cues to prevent freezing of gait. And let's hope this works. Yay. And so what this is, you can see how difficult it is for this person to walk, but then when they have these lines, I mean, it's really a miracle. And then you can see this person continues that effort for a few steps after. You have to keep on imagining you have those lines. Sorry. So how do we manage freezing of gait? So here's some ways that we can prevent this or help to reduce the incidence of it. So if you're starting to walk, you can shift one weight to the one leg before swinging the other leg forward. when you're turning in narrow corners, take a wide turn or imagine stepping over a line. When you're in tight quarters, this happens a lot of times. People in New York City, I've talked to a lot of them, it's a difficult place for freezing of gait. You want to create wider spaces. So in your home, you have a visit by an occupational therapist who can come in and actually create these spaces that are wider for you. A lot of people feel rushed, like they've got to get to somewhere really quick, and they're the ones holding everybody up. That leads to more freezing of gait. So basically, we try to behavior modification to reduce that anxiety. In crowded situations, very similarly, reducing anxiety can help. Dual tasking, when you're walking, if you have freezing, tune everything else out. Try to just focus on on the walking, only. So here's all the different other methods that we found for dopamine responsive freezing of gait. Again, these are people who actually do respond to levodopa. So it's the levodopa responsive freezing of gait. Obviously, levodopa itself is going to help. Dopamine agonists, such as ropinirole, also called Requip, Mirapex or pramipexole. There's another one, there's a patch called rotigotine or Nupro. They can actually worsen or improve freezing of gait depending. So that's kind of ambiguous, so we're not sure if that really helps. This medication does help, anecdotally in my experience, but also with the studies do show it helps as well. They're MAOB inhibitors, and what that does is it reduces the breakdown of dopamine. They're called rasagiline or selegiline. A lot of people take these because they're potentially neuroprotective against Parkinson's disease, but they can also help with freezing of gait. They have very few side effects. So I often will start with this unless the freezing of gait is very severe. These are for deep brain stimulation. There has been some improvement with the STN stimulation, and the GPI, not as much of an improvement. Methylphenidate is Ritalin. It's very interesting. It kind of acts on that area of the brain that's also associated with being really sleepy and also with acting out dreams. So that's called the locus coeruleus. And methylphenidate or Ritalin acts on that area. A lot of times I see people who have the fluctuations of the freezing, and that's because the carbidopa, levodopa works, then it doesn't work, and works, and doesn't work. So if that happens, you can go with the intraduodenal levodopa gel. This is called LCIG, levodopa, carbidopa, intestinal gel, or Duopa is the name that most people know it by. This, bypasses the stomach, and it makes it so that the carbidopa, levodopa works more frequently and fluidly, and it can be really effective for freezing a gait. In my opinion, more effective than deep brain stimulation, thinking about advanced treatments for Parkinson's. Something called apomorphine. This is an injection. I would not recommend this. This causes nausea, vomiting. Amantadine I would recommend, even though it says inconsistent data. Amantadine is very helpful for freezing of gait. This is my second line medication. I will usually try rasagiline or selegiline first because it has little side effects. But if it's severe, I'll give amantadine. The limiting effect of amantadine is it can cause hallucinations. It usually happens in people over 70, over 75, and usually at night. So what I try to do is give the amantadine in the morning or early afternoon, and then basically use the other methods seen on the previous page at night. So therefore, you can use the amantadine in the morning. That's when hallucinations are less likely to occur. And then you can use the kind of conventional measures that don't involve medication later at night to avoid the side effects of amantadine. Going down the list here, these are really kind of experimental. The electroconvulsive therapy, please don't. Transcranial direct current stimulation works transiently, but doesn't really work that well long term. This is a form of deep brain stimulation, PPN stimulation. That's very experimental. Botox injections have actually been felt to work, but the problem is if you inject in the legs, it can cause weakness. This is a lot of other different ways. I want to jump down here to all types of freezing of gait. Physiotherapy is the best way. So anybody with freezing of gait, one of the first things I'm going to do is ask you to go to physical therapy. I usually ask people, please just go one time. That's all you have to go to. If you don't like it, don't go again. And that usually gets everybody on the hook because then they like going and they'll continue to go. So it's a really helpful method. And remember, physical therapy doesn't have side effects like a medication does. So, the physiotherapy, they use rhythmic auditory cues and visual cues. We saw an example of that. There's the walker stick projecting a laser line on the floor. There's educational therapy. And then with occupational therapy as well, as we saw previously, they can come to your home and kind of clear out the clutter so there's less freezing. So for the treatment of the freezing, if the freezing is responsive to the carbidopa-levodopa, we want to reduce that off time. And that means more frequent dosing or other medications like Rytari. Again, that levodopa, carbidopa, intestinal gel can reduce off time. The medications, first I would go with rasagiline. This is the MAOB inhibitor, prolongs the half-life of dopamine, and it has very few side effects. Amantadine, again, likely the most effective medication, but you have to monitor for those side effects, hallucinations being the most troublesome. Physical therapy has the best evidence for the treatment of freezing of gait, and this includes things like shifting weight, making wider turns, concentrating on your area around you, and taking larger steps forward or using rhythmic auditory cues. The visual cues are mainly this laser light, but for those of you who don't have access to laser light and have freezing, try to picture a horizontal line in front of your feet, tune everything else out, and just step over that line. That usually breaks the freeze and gets people going. But these laser lights, they have them now for shoes, canes, and also on something called a U-step walker. For those of you who are falling, the U-step walker is a fantastic device. It's a weighted walker, so you first of all have to squeeze it to go, not to stop. You have to squeeze it to go. So if you can't really go and you need to stop, you just release. Also, because it's very weighted, if you fall backwards, this walker will prevent you from falling backwards. It's very helpful. But then I wanted to talk a little bit about some research that I was doing. Some of it's just kind of fun. Some of it will be more relevant for you. So what we're working on is developing a virtual reality paradigm to assess the freezing of gait in Parkinson's. Again, you have all these different methods of assessing freezing of gait that we discussed, and they're really kind of flawed except for this FOG assessment course. The problem is, again, so these ways of assessing freezing of gait are not perfect. The FOG-Q is a self-report measure. It's very overly sensitive. That clinical exam by the UPDRS is a snapshot percent of the tray and walk, and that's can induce falls. So the studies to date have likely misclassified people with freezing of gait. So future research and clinical trials need a safe, accurate measure. And so therefore we wanted to develop a quantitative assessment tool to determine if therapeutic interventions are effective. So this virtual reality paradigm would offer a safe measure to evaluate the frequency and severity of freezing. It's useful in clinical trials to evaluate the efficacy of various measures. There's actually MRI-compatible pedals that can further elucidate the pathophysiology of the freezing of gait. So we would actually have people in an MRI using pedals going through this course, and we could see what's going on in the brain when episodes of freezing of gait occur. So the idea was to look for the underlying networks that can cause the freezing of gait so we can find better therapies besides levodopa for treating freezing of gait. So I wanted to show you what they were using previously. This was designed by a group in Australia. It's actually really inventive. This is a video game called Doom. So you can see here, you're walking through a narrow hallway. There's a doorway that you have to go through. It's a video game though, so it doesn't really look like real life, like we were hoping to, and therefore it's hard to tell if it's actually inducing freezing of gait or if it's more of just being in kind of this alternate universe. So we conducted a feasibility study for a virtual reality paradigm to assess the freezing of gait assessment score course to evaluate freezing of gait. In phase 1, we looked at 5 people with freezing, 5 PD patients without freezing, and 5 healthy participants. And we had them go through the FOG assessment score course and also the virtual reality paradigm. What we wanted to do, we did this first outside, of the MRI to see if the pedals would actually capture episodes of freezing of gait. I'll show you a video on that. And then this is some science talk. After that, we did it inside of the MRI to see if it would actually work inside of the MRI. We could see what's going on in people's brains during the episodes. So here is the freezing of gait a course, the freezing of gait assessments course, also called the FOG score. So you can see here, this is a first-person view of somebody standing up. Then they're going to turn. The first turn is going to be to the counterclockwise. And so again, what's happening is somebody's actually pressing on pedals to induce this, simulating what it's like for walking. But you can avoid the danger of actually going through the course. Here is somebody who's actually watching that course with the pedals. I'm sorry about the granulation, the pixels. But you can see here, this is a wonderful lady. She helped us with the study. And she's taking the steps forward. And each time she takes a step, she goes through forward in the course. So what we found, freezing of gait obviously is a disabling phenomenon. It frequently causes falls and subsequent morbidity and mortality. There are few effective therapeutic interventions for freezing of gait currently, so we're working on ways that we can find better treatments, especially for the non-levodopa responsive freezing of gait. That's the most difficult to treat. The underlying pathophysiology appears to involve, basically there's this local motor network within the brain, and it involves structural deterioration of that, and then there's a decreased ability of the cortex to compensate. So really, I'll try to put this in layman's terms. There's a part of the brain that's responsible for walking. It can be affected by Parkinson's disease. And if that part of the brain is affected, initially people can compensate using their cortex, the outside of the brain. But if that deteriorates later on, it can cause, there's an inability to compensate, and then you develop the freezing of gait. So what we hope was that this virtual reality paradigm would offer a safe, effective way to quantify these freezing of gait episodes. Therefore, we can develop future therapeutic modalities. So that covers how to treat freezing of gait, what it is, and what we're doing research-wise. I'd like to open it up for any questions anybody may have. And thank you guys for coming.
Thank you so much. Wow, that was incredible. If you guys have questions, you can feel free to ask them or put them in the chat. You can do that to everyone or privately, but a few have already come in, so I will read some to you if that works for you.
Of course.
Okay. Do verbal cues help?
Yes, definitely. Verbal cues are very helpful. The one thing to avoid is a distraction. So if a verbal cue is not helping, it can actually be a distraction and can further increase freezing of gait episodes. But they have found that auditory and verbal cues definitely do help people with freezing of gait. I would work with your physical therapist, somebody specialized in Parkinson's, through the LSVT BIG program or POWER program, and they can help you work on that.
Okay, wonderful. And if anybody is trying to find LSVT or POWER in their area and you're not sure where to find that, feel free to let us know and we'll help you get linked up with that. So thank you. Is there a way to help with waking up, freezing when waking up?
What that indicates to me is that the carbidopa levodopa, to the person who submitted this question, you're probably taking carbidopa levodopa instant release or a dopamine agonist instant release, and it's probably wearing off before you wake up. The first thing I usually see is, or first thing I would do in that situation is try to put on carbidopa levodopa controlled release, and that can work throughout the night. And so when you wake up, then there's not that wearing off. And so likely that's an off phenomenon again, and you just want to reduce the off issues when waking up, and that can be done with the controlled release medication.
Perfect. Okay. Another one is, does music help?
Music definitely helps. Music's amazing. And so it's a rhythmic auditory cue. And so it's kind of this step, 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 step. I've had some people who actually create little recordings to kind of help themselves to do this, and it really helps as well. So I would definitely recommend that as well. That's something you can develop yourself. I'll be honest, patients have come up with a lot more effective therapies than doctors have for this condition. I've had a patient who had a cane. He would kick the cane in order to get unstuck, and then it would make him go forward. A little bit dangerous, but it was very effective. So, but the rhythmic auditory cues are very effective.
Wow. Okay. And so I'm curious. I had not realized that. I mean, it makes sense that as the carbidopa levodopa is either maybe not absorbing as well, or it's just not working as well as the disease is progressing. That can be an indication that can. So if somebody has a lot of falls, they may not even know that the carbidopa levodopa is not working as well. That could be a clue for that then.
Definitely. So it's really important, and usually it takes about 30 minutes for carbidopa levodopa to start to work, and it starts to wear off after about 4 hours. And so when it starts to wear off, the most common indications are return of motor symptoms. So if there's a tremor, the tremor will start again. If there's slowness or stiffness, people can kind of feel that. I often feel people call it as weakness, but it's really slowness or stiffness or difficulty walking. Along with those return of those motor symptoms, there will also be anxiety, because people, one, can tell the medication's wearing off and they're about to get stuck, and that's a horrible feeling. Two, dopamine itself is responsible for kind of controlling anxiety and depression, along with serotonin. And so if that reduces and you start to feel that anxiety, then that's probably an indication your medications are wearing off, and you should talk with your doctor about getting on a more regular schedule.
Perfect. Okay. And there's two that came through the chat to everyone. One is about the MAO inhibitor Xadago.
Great. Sorry, go ahead. Sorry.
Go ahead. Yep.
Sorry. So the Xadago is like a really powerful version of rasagiline or selegiline. And so it works. I'll go through the science of it. So there's MAOA inhibitors and MAOB inhibitors. You want the MAOB because the MAOA is non-selective. The Xadago works very powerfully on MAOB, not A, and so it's a little bit more potent. So I've used it a couple of times. It only came out about a few months ago, but it has shown that it is effective. So yeah, I probably should have added that onto my list of medications and treatment modalities. It just hasn't been studied informally, and so I can't formally endorse it. Anecdotally, I'll say I think it does help.
Okay, wonderful. So I noticed a note from Rose, and she's talking about some challenges with her husband, and I think part of what she's getting to also is, what do you do when the person that you're working or dealing with doesn't want help or refuses help, and you've got complex issues?
That to me is an indicator that there's possibly some depression going on. It sounds like because apathy is kind of the term for not wanting to get out of a situation, not being motivated to do something. It could be simply an executive dysfunction, a cognitive issue. If it's a cognitive issue, I would either see a memory specialist, cognitive disorder specialist, or a medication called Exelon or ribostigmine, which can help with the cognition in Parkinson's. If it's more of a depression issue, I've coined a term called spousal deafness. And I think after a while, everything kind of falls on deaf ears, and you can say it as much as you want, but you need the physician to get involved and I make people shake and agree on it.
Oh my God. You should trademark that term.
but there's also, if there's depression, then an antidepressant can help. That's because depression is such a taboo in our society. It normally takes a real in-depth discussion with the physician. I see it every day. Depression is very common. It's very taboo. Antidepressants can really help people feel better emotionally and get them motivated to do things that will help them physically.
Thanks for that. And also, as care partners, sometimes you need antidepressants too. This is definitely support, right? We all need them. Exactly.
Yeah.
Okay, so there's another one. Can too much carbidopa levodopa cause freezing?
Great question. So somebody's up on the literature or is insightful, because there is something called on freezing, where it's thought to be a supra-therapeutic dose of the medication causing the freezing of gait. And so in that case, medicine's a lot of common sense. If you have too much medication causing symptoms, what are you going to do? Lower it. So it's a matter of finding that sweet spot. And the best way to tell that is at the peak of the carbidopa-levodopa, which should be about 1 to 2 hours. Or is the freezing occurring then and only then? If it's occurring then and only then, it's likely too much medication.
Excellent. Okay. Can you talk a little bit about carpet and if that impacts freezing?
Great question. I've heard a lot of people tell me that when they change textures of floors that it can induce freezing. So that's a reason why if you're not freezing on a cold, hard surface, porcelain surface, or wood, but then on a carpet you are, then definitely you want to modify your house. And that's when you get occupational therapy involved in a home health evaluation.
And actually, you referenced occupational therapy. I still say that's one of the underutilized therapeutic options. Can you share a little bit more about, I think the name is a misnomer for people. They think it's about working. Could you share a little more about that?
Yeah, yes, 100%. And so you're 100% right. And I'll be honest, I was one of the people who thought occupational therapy, what is this? They teach us in medical school very well about physical therapy. We don't learn a lot about occupational therapy. Occupational therapy is outstanding. You go with what your problem is, they can find a way to help you with it. They are very crafty. For example, people with tremor, oftentimes the farther you hold your hand from the fulcrum, then the more you shake. The closer you bring it to you, the less you shake. That's one of the things an occupational therapist shared with me. They can do tips and tricks that don't cause side effects that can help you with your freezing gait or other symptoms. I would definitely recommend it.
And a physician can order that just like they can order physical therapy, right? I mean, that's covered under Medicare. Yep. So people just need to ask. Okay. Yeah. Let's see. How does DBS impact freezing?
It can be positive or negative. And so it's a complicated issue. Depends upon the site that you were stimulated, the STN or the GPI. Those are the two main sites that people are the DBS is implanted in. The STN has been shown more efficacious for helping freezing of gait than the GPI. DBS can also worsen gait stability and balance. But overall, there's 3 different parameters that we program for the deep brain stimulation: amplitude, pulse width, and frequency. I'll get to the point of this. I'm sorry, it's a little bit tedious. The pulse width, if you reduce that, that's been shown to actually, reducing the pulse width or increasing it in some cases has been shown to improve freezing of gait. So if you have freezing of gait and you have DBS, talk to your doctor about programming it for settings for freezing of gait. I'm not sure I would proceed with DBS for freezing of gait, but oftentimes people who have freezing of gait are more advanced with Parkinson's and have more symptoms. And so freezing of gait can be a good opportunity for treating, DBS can be a good opportunity for treating those other symptoms in addition to the freezing of gait.
Perfect. Okay. And there's a question about what about CBD and marijuana? I don't know if that's a general question or specifically tied to freezing of gait, but that is a question.
Well, I'm in California, so I receive this question every day. And actually, when I was in Nevada, I received it every day. So I'll tell you my spiel for marijuana. There's 2 different parts of marijuana. There is THC and CBD. THC is the Woodstock portion. CBD is the medicinal portion. THC is going to get you the relaxation, but it's also going to get you high. And you'll get munchies and et cetera, but also really sincerely, it causes confusion, can worsen your balance. So THC, I would not recommend for freezing of gait and balance. CBD is a more benign method, more focused on just kind of calming and relaxing things without causing intoxicating side effects. So if I had freezing and I did want to try something, CBD would be the better of the 2 options. Again, freezing a lot of times due to anxiety. I see that oftentimes in the clinic, people are just, and you can imagine, of course, when you're walking and you can't walk, of course you're going to get scared. If you can tone down your anxiety response to that, such as with CBD, theoretically that should help.
Wonderful. Thank you. I like the Woodstock version. I've never heard it described like that, but that was perfect.
Yeah,
Uh,
I think that reaches, a
it just,
lot of us understand what that means.
yeah, you just go, I get it. Okay. So that's
Yeah.
perfect. John P., you have your hand raised. Do you want to ask a question or do you want to type one in?
Hear me okay?
Okay, you're unmuted now.
Oh, okay. If you can hear me okay, I'll go ahead and
Yeah.
talk. So I'm a young, somewhat early onset Parkinson's patient. Was diagnosed in 2010. I was about 44, 45 years old, and been suffering symptoms for about 5, 6 years prior to that. And so I guess my progression may be a little bit different than some of the other folks. And I also, so I have a couple of questions. So a couple about me and one's about my mom. My 85 or 86-year-old mother lives with me now. And so it's kind of, we watch each other.
Yeah.
And so I'm still working. So I noticed that she has freezing of gait. Do these same, but she does not have Parkinson's. Parkinson's runs in my maternal side of the family, though. A lot of my maternal grandfather's family has Parkinson's, apparently. I have a lot of second, third cousins and things who have Parkinson's or have symptoms in aunts and uncles. So having said that, in her case, she seems to exhibit some symptoms of Parkinson's at times, but never diagnosed with anything like that. And she moves fairly well. Is it possible, though, that she could be, do people without Parkinson's have freezing of gait? I guess that was my question.
Yeah, definitely. And the diagnosis of Parkinson's disease is not made by freezing of gait alone. So it's really a clinical diagnosis for Parkinson's. So there's three major symptoms now. Resting tremor, so not when the hands are held up, but when the hand is resting on something, it still shakes. Slowness, and literally you can have somebody do this and see if there's one side that's slower than the other. You can see them trying to make the right side go slower than the left here. And then stiffness, or something called cogwheel rigidity, like a ratchet. Like those old wells had those cogwheels, and they would ratchet around, and that's what it feels like. So I don't want you to be an in-home doctor, but if you really do want to check, those are kind of the three major symptoms to see if there is Parkinson's. That being said, the freezing of gait can be oftentimes with other disorders. With normal pressure hydrocephalus, which I mentioned, the two other symptoms besides the walking difficulty, and the walking is unique with NPH, the feet, instead of walking like this, they walk more far apart, and it's very magnetic. So it's almost inverted. And then there's urinary problems like incontinence and memory problems too. So if there's that triad, then I would be concerned about NPH, because that's the other disorder I see it commonly in. Again, there can be little strokes too that cause just that one area of the brain to be affected, and it can cause the freezing of gait. So it can also be in other disorders that are like Parkinson's but not Parkinson's. I think I should never play internet doctor. I would recommend having your mom seen by a physician if she's willing to. If not, if you want to do a home check on those, it might help. But I hope that helps.
That's great. And it's a good reminder that, I always like to make sure to put a plug in that it's really important that people see a movement disorder specialist, ideally. I know they're not everywhere, but even if it's not, it may not be, you may only be able to see the movement disorder specialist once a year, but, this is a neurologist who has advanced training in Parkinson's and other movement disorders, and will not only be able to really identify and diagnose properly, but also will know the right treatments and how to put treatments together specifically for you. So, and of course, Dr. Bluett is a movement disorder specialist, but it's just a really important component of accurate treatment. Okay, I have something here. Rock Steady Boxing, Dance for PD, and PT. Does regular participation in exercise reduce the impact of freezing? That's a good question.
Oh, definitely. Because there's a lot of reasons why. One, you're keeping yourself mobile. Two, you're increasing your dopamine with exercise, so there's less of those off times. And three, especially with Rock Steady Boxing, if you think about the major symptoms of Parkinson's, slowness, stiffness, and difficulty with reactions, postural instability, boxing is all about reactions and postural stability, and it's fantastic. The Rocksteady boxing course is excellent. I would highly recommend it. There's other versions of it out there, but yes, definitely. Dancing with PD, same thing. You're moving your feet quickly. You're learning how to position yourself. So all of those are really helpful.
Wonderful. You mentioned your research that you're doing some research on studying this. Is this research that people can participate in? Is it people that are local? Because we do have certainly people from California, but all over the country. So I don't know what that availability is.
Great question. We finished the research project that we were doing for the freezing of gait. It's ongoing, but we finished enrolling. That was at the Cleveland Clinic in Las Vegas. Stanford is excellent in regards to freezing of gait in general. Dr. Helen Bronte Stewart is one of the leaders in the country for freezing of gait, and she's working on some deep brain stimulation work that could really change the field. So there's ongoing research. Unfortunately, right now I'm not recruiting any studies, but I'll definitely update if I am.
Perfect. Okay, wonderful. We'll keep our eyes open too, and we'll share information, in our e-newsletter, and anything that you have. We'll certainly be putting this in our e-newsletter as well. Another one just came into that says, is there something I should not do to or for my person with Parkinson's to help them when they're frozen?
Yeah, the time pressure. I see that a lot. Come on, hurry up. And the person can't. And so the pressure just kind of induces anxiety and the person's own frustration with their inabilities. So try to be kind and patient. The one thing I do with the patients when I'm talking with them when they're walking, I will literally say this: tune everything else out, picture a line in front of your feet, step over it. That's it. And once people can break that freeze, one, they can see that they can break it. And two, once they break it, they move more freely. And so I would definitely get involved in physical therapy too to help with this. If you Google online laser light for freezing of gait, there's tons of different things, and they're all pretty good. So those are 3 ways somebody can help right now.
That's great. And because you're right, the tendency is come on, or I've actually seen people kind of pulling, and that's not going to help. So it's really kind of just triggering the brain, isn't it?
Yes.
And then the other piece that struck me too that I think is really important as a takeaway is it is not the time to multitask. So let's not have a conversation while you're trying to walk, right? Focus on the walking.
100% agree. Yeah, it's just doing too much at once that's really the problem with freezing of gait. It's an inability to coordinate these thoughts. So you really just have to focus on the walking, and I support what you said completely.
Oh, this has absolutely been wonderful. It's such a significant issue, and it's an issue that is perplexing and frustrating for everybody, and really dangerous.
Yes.
So, I want to mention that you talked about the U-Step walker, and in our e-news, we'll definitely put this video because I can imagine people would want to watch this. And I would also say for people watching this, if you have adult children, friends, families, relatives, this is the kind of thing that's actually really helpful for them to watch, because then they can learn the complexity of the disease, and it will help everybody feel like they can be a part of navigating these challenges.
Exactly. Empowerment is a very important thing for all aspects of diseases.
Yes, absolutely. So we just got another one. Is fog freezing of gait, which I did not know was fog. Is fog only walking, or can it affect driving?
So freezing of gait can affect a lot of things. I probably should have referenced that in the presentation. Sorry, freezing can affect a lot of things. So there can be freezing of hands, freezing of an inability to do one certain task. Obviously, if there's freezing when driving, I would sincerely consider not driving, because you can imagine if you're going towards a red light and you freeze and you can't move, it's just a nightmare to think about what could happen. I would definitely consider not driving if that's an issue. And that's my least favorite part of my job is the license issue. My job is to give independence, not take it away. But let's be honest, we need to be safe. And so I would really consider not driving if that's an issue.
Thank you. That's right. It's a tough one to not have, but boy,
Yeah.
the consequences are so severe. Yeah.
Yeah.
Yeah. I'm going to just throw out one more call in case there's any other questions we haven't answered. This has been just a wealth of information and really helped to understand what's behind the freezing of gait. And it's exciting to hear the research that's, starting to happen and that there's actually people who specialize in this.
Thank you, Sarah. You guys are wonderful. Everything that you're doing is absolutely amazing. You're doing, and I really appreciate the opportunity. I'm always available.
That's wonderful because we love hearing from you.
Thank
You're
you.
absolutely, we're so grateful for your partnership. We're so grateful for your time.